Hello, I'm Dr. John Kruse, and welcome to my question and answer hour. So, we have an hour for me to try to answer questions about the videos released or re released this week about ADHD in general and more broadly about mental health. And sorry about the connection last week. I've continued to have some troubles. So, again, I'm reliant on the satellite Starlink system thanks to Elon Musk because I'm in rural Hawaii. Um, if it fails, I will at least try to type in answers, but we will see what happens. And the video that was just a re-edited this week was on social media and screen time and the impacts or connections with ADHD. My summary is that most of the studies are done in a way we can only look at associations, but there's a clear association between more time spent with online and screens and social media and reduced attention span, greater distractibility, but not just those two, which get lots of media attention, but also greater impulsivity, poorer emotional regulation. So, a broader host of executive dysfunctions than is normally seen. And again, that's a pattern that matches more clearly the whole ADHD picture. And there's certainly a huge wealth of anecdotal information of people taking a vacation or a break or chilling out from that online exposure and feeling more focused, more clear headed, more productive, more calm. So, not sure why FaceTime just opened up. Anyway, so that's what I will say for there. So I see a whole bunch of questions. So I'll try to start answering them. So hello, Jack. Jack asks how I would differentiate between someone with ADHD, someone with autism, and someone with both ADHD and autism. So I do have a video on ADHD and autism, and I probably have sort of more rigid or firmer criteria than many clinicians seem to be using these days for autism. In my opinion, there are many people both self identifying and receiving a label from mental health professionals who don't really have autism, but who seem to have social anxiety and or ADHD and or some other PTSD condition that may mimic some subset. Um, so with ADHD, I think my criteria is that you have to have some executive function dysfunctions in terms of, and I shouldn't call them dysfunctions, different patterns of behavioral and cognitive activity. So less linear thinking or less ability to track time well and show up for appointments or do things in a timely manner, more difficulty initiating tasks, more distractibility, more impulsivity, more likelihood to intrude or interrupt on others, more physical restlessness. So to me, core problems with or challenges with executive functions are need to be there for an ADHD diagnosis. And with autism, the central parts of the diagnosis is challenges with social communication. And that's not a fear or reluctance to engage socially. It's difficulties or differences in how you process that social information. So, and as well as sort of idiosyncratic, narrowly focused hobbies or interests that tend to be dwelling on the details and surface rather than on the essence of those interests and some propensity or degree of repetitive physical behaviors and that are soothing. And there can be a lot of overlap between fidgeting and stimming and different traits there. So I don't know. So the other thing I would say is even though I try to adhere maybe more rigidly or to some of these DSM and other diagnoses, my other thought about labels is that each individual has a right to use the labels that work for them, even if I think they may be inaccurate. You're, you can own your labels, but that doesn't mean I have to agree or buy into it if I don't see that it fits that pattern. So, so, and if let's find ask follow-ups if I didn't get there. So James Alexander, and I didn't realize that I answered some at this, but I wasn't aware that all got cut off. So James Alexander asks, does eating just a can of sardines 3 or 4 days a week risk exposing you to dangerous amounts of heavy metals? Are the general medical recommendations for how much fish you can safely eat a week too high? Is there a level of fish consumption you think is probably safe, or should people try to avoid it? Um, so there's a wealth of, I mean, just evolutionarily and ecologically, the biggest source of protein in most early humans' diets was almost certainly fish. I mean, communities, civilizations centered around waterways, rivers, ports, an ocean. And yes, there's lots of sort of the media attention of the hunters chasing down a mastodon and cutting other big mammals. But if you look worldwide, chasing down big mammals or even small mammals for protein, more of almost most cultures. I don't know the specific number. The evidence suggests most of our protein came from fish. So fish are good. Fish we've adapted to. Fish are healthy. The downside is we've dumped so many different toxins in the waterways and in the ocean that many of our fish are polluted, as well as certain fish stocks are endangered or imperiled. Um, and the I'll oversimplify, the big sources of toxins are heavy metals, which particularly accumulate the higher you go up on the food chain. So things like tunas, which are apex predators, essentially. Well, shark is above them, or orcas can eat them, but they're close to the top of a food chain. There's several steps up, accumulate in certain toxins, so are more dangerous than sardines, which are at the bottom of the heap and are live a shorter life and are less likely to accumulate. So heavy metals and organochemicals like PCBs and some of the plastic derivatives are the two big sources. So I think the FDA has been in general more beholden to, I mean, along the lines of some of RFK's bias before getting in. We'll see what he winds up doing at the end of 4 years as running or ruining health in America. But I mean, the FDA and the Department of Agriculture have been reluctant to intercede or say things are dangerous. So the fact that they put limits on what pregnant women should be consuming in terms of canned tuna um, is probably not a unrealistically low threshold. Now, whether someone who's not a developing fetus is less at risk, probably. Um, but I don't think that any of the government restrictions, at least in the US, are overly restrictive. Um, but there's also lots of variability, and this is a gross oversimplification, but in general, Pacific Ocean's bigger, deeper, and at least in the US, fewer major cities dumping garbage into it. So, Pacific salmon, Pacific other fish species in general are cleaner than Atlantic Ocean. That's a gross big generalization. But when we just say tuna or salmon or sardines, a lot depends also where those were grown, where they lived, and what they were exposed to. So that's my take. That might not be much useful. So I would recommend one trying to get a variety of different fish if you can, because again, if one of your sources, if what if you're only eating one thing and that's contaminated, then you're going to get more buildup over time than if you diversify. But and probably again eating fish lower on the food chain, you're less likely to get toxins, and wild caught are in general less contaminated than food farmed fish. But those are generalizations. The Monterey Bay Aquarium does have some useful guidelines. Some of those are more focused on sustainability of fish stocks, fish in the wild, but some of it is also addressing health or risk for humans. So Dennis asks, hi Dennis, asks a disturbing question. Have I ever worked with a psychopath? How common are they in my patient pool? The reason I ask is he watched a documentary about Ted Bundy and was quite chilled by the nature of his crimes. Um, I could only wonder how scary it must have been for the forensic psychiatrists who had to work with him to profile him and all. Um, so one is when I did residency training I trained at University of California, San Francisco, and and we had options in terms of what clinical rotations. So I did work on a jail forensic unit. So people who were, it was officially both part of the jail and part of the psychiatric hospital at San Francisco General. And at least some of those people who went through probably would qualify for psychopaths. Most surveys suggest that even in the jail so these are broad brush strokes, and there are some differences between psychopaths and sociopaths, but um, probably psychopaths represent 1% or less of the general population. Even in the prison population, it's estimated by some studies only about 10% of criminals. Um, so I almost certainly was exposed to some there. I didn't work long. I mean, if they were stabilized enough, then they would be returned to the jails outside of San Francisco General Hospital. So I had limited interactions there. I estimated, and I don't have it in front of me, I think I've worked with, and most of these are long-term patients. I mean, it's somewhere between 1,000 and 2,000 patients over a 30-year career. And part of that, it might seem like a large number, but since I've worked with some people for 25 plus years, it's someone who was working for 30 years probably saw, on average, saw more patients a night. Anyway, there's only one person I would clearly define or put in the psychopathic realm, and he was more just a manipulator. And I mean, he's dead now, so I'm a little more at liberty. I won't share too much information. I mean, the most manifest was how comfortable he was at committing insurance fraud. So he would, and he did this multiple times, lie about expensive handbags and photographic equipment being stolen and file claims and just calmly discuss it with me, and also participated in some class action medical suit. So he was on injectable testosterone for a while and other medications where he had not suffered any side effects, and wrote up that he had horrible side effects and then deserved compensation there. He also, with his podiatrist, he was seeing on a he had government run insurance, and the podiatrist was billing him for weekly sessions over several years, even though he would only see the guy every 3 months or so. And he was complicit, and they actually even split the money coming in. I thought I actually tried to report indirectly. Um, so he was constantly, without any apparent remorse or sense of guilt, exploitative, but I don't, and one of the worst. So he was also in A and sober for 30 years before he died, at least. What was I going to say there? But and hadn't been going to AA for about a decade, and then when he resumed, he started mentoring several people in a local who were living at a rehab location near his home, and then wound up bringing several of them back to his apartment, ostensibly or initially for counseling or AA. They don't call it counseling, mentoring, sponsoring, but then started using marijuana with these people who were supposed to be sober from all substances. And he knew that, but he didn't believe that that was a valid or meaningful rule. And even when he was called to account for that and told by that rehab hospital or rehab center that he wasn't eligible to come into their building to participate in the AA groups, he was indigent and tried to sue them for discrimination there. So again, no violent, so I wasn't worried there, but there were lots of ethical issues to execute in terms of interacting with him and trying to set limits and not knowing what I was doing that might be being manipulated or exploited. So I hope that is hopeful or helpful. Uh, so James Alexander asks, if a medical student or resident has had bad enough ADHD to need their meds to do their clinical duties, how can they handle night shifts if even long-lasting meds only last 10 to 12 hours and boosters last another 4 to 5 hours? Do they take an extra dose of the long-lasting meds at night? So one thing to remember is the saying that people with ADHD are interest-driven and people with neurotypical brains are importance-driven. So presumably anyone who's gotten through the system far enough to be a medical student or in residency is interested in some aspect of what they're doing. And if you're working up an interesting case, if you're admitting a new person and you have to make a diagnosis and formulation, if you're following an intricate clinical course, that's compelling or interesting enough so that the moments of vulnerability or problem with someone with ADHD are probably more the long waiting, particularly on shift or on call. It's waiting around when nothing is happening. And, if nothing is happening, then it doesn't matter as much if your mind is drifting or you're playing video games or doing other things. So that's how I would try to frame or approach again ADHD, even though it may be present, it may not be disruptive. Again, depending on it, if you can apply yourself to the task, and if it doesn't matter how much you're on task when you're not doing a task. That would be my thinking or framing or part of the answer to that question. So thanks, Max, for providing the link to the autism spectrum disorder ADHD video. So Max asks sort of a hypothetical question, which I may just defer on. If I had all the funding I wanted in any potential human group at my disposal, but you could only fund one single study, what would be about or directed towards? I guess, I mean, when I'm always offered hypotheticals, I always want to ask more questions to define or parameterize what's going on. I mean, is the goal, or if I had all the money I wanted and could study, I would take Donald Trump and his whole cabinet and isolate them and conduct a study to figure out why they were so willing to engage in so many policy actions that are so overtly and clearly destructive to democracy, to the lives and healths of so many Americans and people worldwide, to so that's not a specific experiment. I mean, we could come up with the specific framing or questions. So I'll essentially pass on doing that one any further. Um, so Rick Roll, hi again. Um, Dude, I think memantine, not amantadine, can serve as a monotherapy for ADHD. I have ADHD, PTSD, and can't tolerate stimulants. I'm trying Cafe to see if it allows me to take stimulants. Um, so there's a little research on memantine. Um, so two different questions. One is, are there any specific individuals who that might be the whole answer to? And I'd say probably. And then the bigger question is, are there many people, or would it commonly be a reasonable choice to be starting memantine and hoping that that's good and effective therapy? So the research on memantine in ADHD is small but limited, and it's encouraging that some people have some reduction in ADHD symptoms. They didn't seem to get as much benefit as people get from amphetamine-based products, but clearly the side effect risks are lower. Um, so I put it in the range of it's reasonable to consider for many people, and I put it at that. So again, I should have given my normal um, not warning blanket statement that this what I'm saying here is for informational purposes only and not specific recommendations, since I don't have a doctor-patient relationship with any of you. Um, since I don't have the full background, I don't have the details and the lab results and a connection in that way. Hopefully, I think I have a connection with some of you. Certainly, we've been chiming in for many, many months here now with questions. So Max's forward a Reddit page. So I should also give a shout out to the Reddit, to the subreddit, where people can ask and engage in more detailed discussions than they might hear on YouTube about some of these topics. So successful while. Do I have an opinion on memantine in relation to ADHD? Is it better than nothing? Can it serve as monotherapy? So that actually tracks really well with what I just answered for Rick Roll. So again, I think I do have I know I've talked about memantine. I'm trying to remember which video it might have been labeled in. Again, I have talked about amantadine too. Memantine was devised as maybe more specifically focused on glutamate systems than amantadine. Amantadine, on the other hand, seems, and this is preliminary, to have more anti-inflammatory, or pro-mitochondrial benefits, antioxidant capability. I would be as likely to try someone on amantadine as I was on memantine if we were looking for alternatives for ADHD. But so this individual, so I'm seeing there's a second part of the question, didn't tolerate amantadine very well because it exacerbated tics, likely due to its dopaminergic effects. I also don't tolerate stimulants very well due to anxiety, PTSD, and OCD. So the other um, thing we've talked about here frequently is that in many ways that's a very typical or ideal situation for guanfacine, um, alpha 2 adrenergic agent. Um, so many people who could not tolerate a stimulant because it was too stimulating stop the stimulant, start on guanfacine. Some of them, it's adequate enough to treat their ADHD symptoms. Others get some improvement, but not enough. And then when they restart the stimulants, and restarting at a low dose, can tolerate the stimulants that were intolerable before. So one of guanfacine's big clinical roles is helping people be tolerant to the stimulants that they weren't without its presence. So Samuel Fleischer um, is asking, what's my opinion about psychedelics to cure ADHD? So my first part of the answer is addressing the second part of the question. I don't know how often we are curing ADHD. I think more often, like diabetes or other chronic conditions, we are treating it. My understanding or comprehension of this is for most people, it involves circuitry that's different underlying the neurodivergence, and it's not just a chemical dopamine too high here, too low here, glutamate too high here, too low there. So, at a superficial level, I think it's unlikely psychedelics will cure ADHD. Um, there's extremely little research. Most of the research on psychedelics has been on mood disorders, depression, anxiety, less so on bipolar disorder, some on certainly on PTSD, certainly on substance abuse. And for some people, it's even single or just a few isolated dosages. That's usually not microdosing, but have profound years later benefits still persist. Um, Most of the direct effects of the psychedelics are due to serotonin 2. If I say 2A, I might be wrong, but I think it's 2A off the top of my head. It's system which hasn't been strongly implicated in ADHD, but all of these systems interact and talk with each other. I had, and this was more than 10, 12 years ago. This was before psychedelics became as popular as a research and popular topic. I had two different people who took ayahuasca trips. One had Brazilian heritage, and that's what attracted him to it. Both with ADHD, and both felt that it had profound effects on their ADHD for months or years afterwards. And yet, from what I could see from the outside, neither of those individuals changed in their high level of distractibility, impulsivity. To me, it looked like their whole ADHD symptomatology was unaffected. I mean, maybe they were more comfortable with their life or accepting or could reframe it in ways that was less distressing to them. So that's what I would say with psychedelics. Okay. So Rick Roll, thanks for participating on the Reddit, and thanks for showing up here in person or on remotely in person, whatever, or virtually. So hopefully I answered or addressed at least part of the question. So James Alexander asks or says, some ADHD patients online report their primary care doctors are only comfortable prescribing phentermine for ADHD. Have you ever come across phentermine as an ADHD treatment? So yes, I actually used it moderately often way back in the early or mid 90s when I was just starting out. So it's less tightly controlled. It's still a controlled substance. I'm not remembering which schedule as a stimulant. So it it does have some pathomimetic qualities. It clearly there's a tiny bit of evidence that it, formal studies that it can treat ADHD symptoms. And again, it's just being less tightly regulated makes it attractive to some people. Whether it's actually less risk for substance abuse, whether it's less risk for psychosis, whether it's less risk for cardiac problems, those are the rare or uncommon severe side effects. I don't know that we have good evidence that it's actually better or safer. It was also part of, and this is dating me, so it might mean nothing to many people in the, I think it was mid late 90s. Fen-phen, so fenfluramine and phentermine were combined as a weight loss regimen. which was very effective for weight loss. And then there were several dozen people identified with heart valve abnormalities, and that combination of medications, and I think fenfluramine itself was taken off the market. I may be wrong on that. Certainly, phentermine's there. That certainly depressed interest in using phentermine. And I have at least one cardiologist, an academic cardiologist, who feels that the evidence linking fenfluramine, phentermine combinations to heart valve abnormalities was actually fairly weak and circumstantial and hadn't nailed down a causative role. There have been other, again, I'm not remembering which serotonergic sub receptor system that fenfluramine acts on. There have been other drugs with that mechanism of action implicated in other heart valve abnormalities. Anyway, where am I going with that? So yes, I used it. I think it was less effective than amphetamine-based products, but certainly comparable to Ritalin methylphenidate. I mean, the disadvantages is, as far as I know, it's only available there is a, it's not, there aren't complicated long-acting forms or releasing some short-acting now and long-acting later. There aren't tweaking the stereoisomer ratios, so it's just available. There's phentermine, and I'm not remembering off the top of my head what its expected duration of action is in people. So James Alexander asks, for the patients I've mentioned who say they're autistic but whose symptoms are apparently caused by PTSD-like condition, how'd they present clinically? How'd their PTSD traits resemble autism? So, and I focus on probably as many people I would put in the social anxiety realm. They talked about being uncomfortable in groups, of being uncomfortable being scrutinized, of wanting to be connected with people, but being ashamed or embarrassed or triggered or traumatized. And again, almost part of my bias or my thinking is if there's so much of their internal life is focused on yearning and trying to connect and feeling rejected, that to me does not fit the core element of autism, where it's sort of disregard. I mean, the extreme end of the spectrum, it's easier to see sort of the child whose eye movements don't track the adult's eyes around them. That is so basic and human, at least when we're not online and when I'm talking into a screen and not even sure where my eyes are looking right now. So that's not an aversion. They're not specifically avoiding people's eyes. It's that information which others deem as important social information is just not on their radar or responsivity. So anyone who's unduly focused on social interactions, to me, raises a suspicion that autism may not be really part of what's going on. That doesn't mean there certainly can be people on the autistic spectrum who have felt rejected, have felt bad, who feels there's something off or different or neurodivergent about how they approach things and feel left out because of that. But if so much of your energy is directed on that, that almost seems to undercut a claim that it's primarily you're suffering from primarily a deficit of social awareness, social communication, social processing. So I'm not sure if that. So the question was more specifically, how are they presenting, or how are they? Yeah. So again, it's being fearful, feeling awkward, feeling self-conscious in social situations. And so thanks, Max, for providing the link to guanfacine and ADHD. So Max asks, how deeply do I dive into the studies that I cite for my videos? Do you often find studies that seem promising at first and then realize their methodology is faulty or conclusions are wrong? Um, I'd say it varies a lot with the topic. And again, on many of the topics, particularly with supplements, there's just so few studies. I can read them all and acknowledge their methodologic shortcomings. Um, Many times, and you could argue this is a crutch or a failing. I'm on topics that there are broader array of studies, then I do usually, if there are meta-analyses, look at what the meta-analyses say, and if they're singling out and usually they don't specifically try to single out, but you can, reading through them, if they're just, and in modern day meta-analyses are often ranking the quality or rigor or areas that the con um, the constituent tests or studies are not meeting or are meeting certain criteria, that can help focus in on which, if I do go backwards and then pick out some of the individual studies, that can help me determine which ones to focus on. And it also, again, does give me, whether I agree completely or not with the meta-analysis assumptions or conclusions, whether it certainly shapes how I interpret what research is out there on the topic. Um, so, do I often find studies that seem promising at first and then realize their methodology is faulty or conclusions are wrong? So, yes. So, one of the recent topics I investigated was so I have talked before on neurofeedback and how the video I did on neurofeedback and ADHD, I think, is almost 2 years old, to give or take half a year. And I did that right after probably the largest and most rigorously designed study for neurofeedback for ADHD was published. It was in the American Journal of Psychiatry. And the conclusion from that individual study was they could not tell any positive impact from ADHD beyond just the general impact of being in a study and being evaluated and treated. And there was an accompanying editorial, forgetting the snappy title, but it was essentially saying we should just stop offering neurofeedback as a treatment for ADHD. We should stop. There's no point in doing more testing on it. All the studies so far after 50 years have been unproductive. So since that time, there were two meta-analyses, which also both, I'd say the fair conclusion from both was the field has not shown that this is effective. One of those meta-analyses was more consistent in terms of their conclusions and saying that. The other one said, the findings are really inconsistent, but there's, maybe in these positive studies, we should look for the direction to go. Anyway, there's a new study that got a fair amount of attention, maybe not as much attention as should merit, and it's not specifically on ADHD. It was using neurofeedback to look at meth addiction, um, and their methodology was distinctly different than most of what's been used before, and it was looking at whole brain activity. Almost all neurofeedback studies, whether they're using functional MRI or EEG, look at brain activity in a certain part of the brain and then try to change that, thinking, aha, we're dealing with reward circuitry, that's going to help with addiction, or we're dealing with emotional modulation, that's going to help with depression, or we're dealing with prefrontal cortex, executive functions, that will help your ADHD. Or so again, this looked at whole brain activity and got a real-time composite capture of what that activity looked like, and trained patient subjects to decrease that activity, which resulted in substantial meth craving when re-exposed to cues. And that's a powerful result. And but the study actually didn't have any real life consequences. So they didn't follow up to see, once these people were released from the rehab hospital, are they really using less? Um, I mean, we know all previous studies show reduced craving is a good marker and strongly correlated with subsequent use or ongoing use. But so, that study had a significant limitation. Similarly, the studies looking at lithium orotate or the studies looking at amlodipine for ADHD sort of lack the crucial lots of basic science was summed over or new experiments added to. So they provided substantial basis to think these may be clinically useful or meaningful, but didn't even have any clinical data of we give 10 people this as treatment and see how well their ADHD responds. So on the other hand, again, particularly this EEG study, I think even without the clinical data, I think it has a much bigger, stronger, more important message that needs to be trumpeted and talked about. And again, that is that by targeting whole brain activity, they were more effective than the treatments that target the specific circuits we think are involved. And that has pretty profound implications, I'd say, for almost all mental health treatment research, because, and it's sort of cuts to many of the problems with modern psychiatric diagnosis and treatment, that we have so many people who have criteria for one condition will meet criteria for more than one condition, and also that people who have a condition can arrive at a condition by apparently different paths or circuits or different levels of genetic predisposition, early life experience, and whatever. And again, this is getting down to with meth addicts, you can probably you have craving to meth when you're shown a picture of the meth itself or an injection needle or whatever cue you're using. In each individual, it's going to be a different set of reasons, brain processes that contributed to why that is craving now. I mean, clearly some of it's going to be involving addiction and reward processing, but some of it's idiosyncratic, and that it was an approach that encompasses and addresses that whole picture that's more powerful than the reductionistic approach we were hoping would work for solving problems with our brains. So that's a long answer, I hope. But so James Alexander is following up in extreme cases where the ADHD is present and disruptive during a night shift. What pharmacologic options does a medical student resident have? Is it just taking a right dose of 5-ounce Adderall, XR, Mideas every time they have a night shift? Um, yeah, so I don't know that I have that much more to say, except I will say this for historical framing. I have multiple peers, so I'm in my mid 60s, who trained in medicine at a time when there was no awareness that adults had ADHD. Some of these individuals have pretty significant ADHD. Clearly, they were all bright, they were hardworking, they were again interested enough in what they were doing and able to challenge it, channel their interest or energies into what they were doing, and have had moderately or to some very successful careers in medicine. And they were doing this in an era when absolutely, without question, the number of hours people were on call, the number of durations that you were on call at a time, that the working conditions were much more arduous, and these people found ways to survive. I mean, maybe it was relying on caffeine, but it wasn't relying for most of them on, they weren't doing contraband Adderall or street meth or other stimulant, more powerful stimulants. So what I'm saying is that in a previous era, there was certainly, when it was, I think, in arguably more arduous and less humane conditions, people with severe ADHD still found ways to cope or manage. That, to me, that's an important framing of the question. Jack asks, what's the best treatment for ADHD and autism combined? And my flippant answer is the best treatment is one that works for you. So, although we have a range of options and an expanding range of options in terms of what helps with ADHD symptoms, and again, it starts with the stimulants and then moves to other drugs that are promoting dopamine and norepinephrine availability. In terms of autism, we are severely hamstrung in terms of having very few choices or options that seem to do much that address the core autistic symptoms. So, in terms of, I mean, it's good. And I'm re looking at the question. You actually say best treatment rather than best medication. Um, I mean, if there are prominent ADHD symptoms, we know in the setting of autism with ADHD, ADHD medications do seem to work. Right now, I would say some of the behavioral approaches and training are probably as helpful as any medications, and that's an overall generalization because certain individuals will differ. Um, so the best treatment may be combining stimulants with behavioral strategies that seem to target the autism spectrum issues. James Alexander says every category of medications approved by the FDA for ADHD, stimulants, SNRIs, and alpha adrenergic agonists can cause acute angle closure glaucoma or aggravate chronic angle closure glaucoma. Have you ever treated ADHD patients with angle closure glaucoma? And how did their glaucoma affect their treatment? Um, I can say, having dealt with it just has not ever. I get it's a warning. I get it's a potential risk. I cannot recall a single individual where it presented any clinical problems or exacerbations of the glaucoma. Um, yeah, that's and there. So, and I guess it's because it's in gray that it's harder for me to read the names. JC Skatehill says, I've been on 10 milligrams extended release Adderall this month. Next month, I'll start on 15 extended release. Any benefits I should be aware of? And he weighs 200 pounds and is an active person. Um, so, so what I'd say a few things there. Lots of things I can say there. So one is, although there probably is some crude, rough correlation between body size and activity levels and medication dose, it's really weak and tenuous. And I pick the same examples over time. So I did have a 300-pound truck driver who, on just 5 milligrams, I'm not remembering now whether it's Adderall or Ritalin, was fine. And some of you who follow me might remember better. But on 10 milligrams was too jacked up and overactivated, overstimulated. I had two, and when I started working with them, they were college age sisters who were for decade and almost a decade, maybe at least a decade. One was on 180 milligrams, one was on 240 milligrams of Adderall, and would sit there calmly. I mean, it did help their ADHD inattentiveness, but they were not overstimulated. They were not jacked up by it. So there's huge individual variability. So the other things that are, to me, a little troubling and I'm overreading and over criticizing are any benefits I should be aware of. My thought, or the way I practice, is one of the things the doctor should be talking about. You're going to take this medication because we expect these benefits. These benefits are um, better able to track an activity and stay on the activity when you're doing it, maybe help with motivation in getting started, maybe help with an improvement in time management, maybe a decrease in distractibility. But going through what are the symptoms that you're coming to treatment for, and the benefit should be improvement in those specific symptoms or acknowledgement that Now, yes, this is one of the aspects of your ADHD and one that we don't expect to resolve to that. So, so I think emphasis on expectation of how it's going to help with benefits and side effects should be front and center. Maybe it was or is. The other thing to me that's problematic is we know that the vast majority of benefit from Adderall you see the day you're taking it. Whether there is some additional accumulative benefit from being on it for weeks or months, possibly. Um, whether that's directly a medication benefit or whether that's you're learning new patterns of behavior that you've trained your brain to work more effectively. It's hard to discern. But to me, it is if you're getting suboptimal benefits on 10 milligrams extended release, there is absolutely no point in sitting a whole month at that dose. That's wasting your time. It's wasting, you should be more aggressively trying a higher dose. And if the higher dose either is causing symptoms, causing side effects, then maybe maybe you were at the optimal dose. But there's not a lot of logic that I can find to why you would sit for a whole month at a dose that's not particularly effective. So, sorry. So James Alexander asks, what sort of stimulant medication side effects should cause patients to stop taking the medications right away? Bad enough headaches, eye aches, anxiety, high heart rate, high blood pressure. So, as we say in psychotherapy, often that we should avoid shoulds. Um, I think part of my job is to treat individuals as individuals. I mean, using the knowledge I know collectively about humans and how they behave and how certain patterns like depression, anxiety, ADHD affect behavior, and also how medications in general affect behavior. So, a couple things. So, I'd say the only side effect that to me is an absolute, you have to stop it, is psychosis. If you are becoming paranoid and delusional, that to me is you need to stop the medication, and I'm not comfortable prescribing it again. Some of these others, bad headaches, eye aches, very often, I mean, if they felt intolerable, then my approach is drop the dose in half if you're comfortable, and that this is something that for most people goes away within a few days. So that would also apply to anxiety, high heart rate, high blood pressure. I'll get to in a second. But most of those side effects are very clearly dose dependent. So it might be that we just started at too high a dose for you, but most of them also people become tolerant to or accepting of very readily, or within a few days. And this is harder. I don't know how rigorously it's been studied, but my strong clinical impression is if you're dealing with a side effect, you are much more likely to see it diminish and go away by the end of a week or 2 weeks if you take the medication regularly. If you take it one day and then take a day or two off and then take it again, you're likely to be confronted by the same severity. The side effects each time you retry it, you're not developing tolerance or waning. The other challenging part of this is that all of those side effects, are also correlated with anxiety. And if you're freaked out that, you didn't tell me I could have eye aches and my eyes are hurting, and then there can be feedback loops of expectation. Oh my God, this is a medicine that's going to make my blood pressure go up. Should I, that itself is going to make your blood pressure go up when you take it. So yes, there are blood pressure, if your blood pressure is in the 180, 90, 200 systolic range, I would be very unlikely to encourage someone to persist in taking it. Um, but substantial elevations that are below a immediately dangerous range, again, I would work on reducing feedback loops that are primarily anxiety, panic related that can exacerbate all of those side effects. So Max asked, has interacting more with social media through your videos led you to change your views about it at all? Do you think that despite its flaws, it still has positive value? Um, One thing that's moderately interesting, maybe it's not that it's idiosyncratic. I still don't look, I just don't gather much information. I mean, even though I've put out now more than 200, maybe it's even up to 300 informational videos. I've watched almost none of my own videos myself. That's bad. I should be looking to see how much my body language, my eye positioning, my parsing of language, what I'm saying. I mean, I should be watching more to get better at this. Um, but two, it's just not a good way for me to find or research information. So I think it's moderately surprising how little I had to force myself to watch my Huberman interview. I think I put it on fast forward and saw it in a couple sections. So most of I mean, one is I like processing information at the speed my brain works to process it, which is a reading speed, which you can slow down or speed up or skim over or go back. Or so I think that sense of control. And yes, you can speed up, you can go forward or back on video. I'm just not fluent in doing that. Um, I do think visual processing for me is more effective than auditory processing. Um, so yeah, so those are more the personal end than rather the value of. I mean, part of it is I know people learn differently. People different routes of information are more appealing, more useful to some people, to many people than others. Um, so So have I changed my views on it at all? I also, I mean, I've seen very little TikTok. I don't, and I would get back to maybe the most important one clinically is the news. So almost all the news I get is also from reading. And I think I understand and know as much of what's going on as virtually anyone I talk to, including people who are writing and talking about this online for a living. I'm not saying my knowledge base is the top 1%, but it's pretty good and comprehensive. Two, I seem to have more, maybe because I've lived longer, um, historical perspective or balance, or can frame things in terms of relevant previous things that often seem to get dropped or missed. And again, I think some of that is from focusing on the video, social media angle rather than a written one. But in terms of being triggered, again, that sense of control. If you're reading it, it's more easy to stop at any moment. It's more easy to slow it down if it feels overwhelming. If you're not watching pictures, you are less emotionally triggered. Not that I can certainly get angry, upset, and righteous indignation at all the horrors that are being wreaked on our world right now, and how blithely so many people seem to think this is good or okay because there's something inherently positive about our current leadership. Um, yeah, so there, I think most people getting most of their news from video and online is, I don't think, a helpful historical. development. So I don't know that I've changed that much in that realm in terms of my opinion. So Jack asks, why are there so many cases of ADHD and autism combined? So there are some researchers who believe that they are fundamentally at some neurodevelopmental level the same thing originally, and that they diverge or divulge in two different directions. That I don't I don't think the evidence supports it that much, but there is again strong genetic overlap, more so than between many other mental health conditions, which themselves, almost all of them show some genetic overlap or are in the polygenic influence. Many of the genes that push people to one condition push them to any condition. Um, yeah, so I'd say some part of it is strong cogenetic predisposition. Whether there are also environmental early life conditions that predispose people to both, that's possible, and I'd say less definitively so. So we're at an hour. So Max, provide a link. So I was interviewed by Yoga with Jake, and that podcast is provide a link to. James Alexander, I'll probably pass in terms of what was my experience with psychotherapy like. Or what I will say is I had more insight. The and Woody Allen I know is in disfavor, but he's sort of the prototypical New York Jewish psychotherapy obsessed individual, put his life out there, at least in the era I was growing up or watching movies in, so that the stereotypical value of psychotherapy is you'll, have this insightful, revealing moment that puts things in perspective. And I have had more such experience in terms of delivering psychotherapy or talking with patients than I ever had in my own psychotherapy. Um, there, that's again. Then that we could discuss whether that's the biggest or best reason to be in psychotherapy or elsewise. Else, Dylan asks, is ADHD and alcoholism common? I don't have the specific numbers, and I'm trying to race through what's going through here now. ADHD, I mean, one is alcohol is the most common substance disorder, certainly in America and most Western societies. So, one is it itself is fairly common. Two, ADHD approximately doubles the risk for having any substance abuse disorder. And again, given that alcoholism is the most common one, that in itself says yes. So there is an association between the two. And it appears that the risk for substance abuse problems is both tied to impulsivity and also to inattention. So the impulsivity is making decisions without thinking of the full ramifications, but the attentiveness is that you're probably not even registering aware of all the consequences, either from not listening to teachers or not seeing the connections in your friends or other reasons. If patients, so James Alexander asks, if patients don't feel any improvement in their ADHD from provisional individual SUNOSI within the first 3 days of taking a given dose, how probable is that they'll eventually notice an effect if they stay on it for another week or month? I have less clinical experience with SUNOSI, but certainly with Provigil and Nuvigil, most people who I think are going to respond for ADHD or for alertness, daytime sleepiness will show it right away. And if they don't, then they probably need to go up on the dose. How quickly SUNOSI works, Um, I would expect then I mean, that's a different, presumably, neurochemical alerting system being activated. Um, but again, I would expect for most individuals that they would notice right away, or it's not likely to be effective. So I, I can't rule out some people may show benefit after a week that weren't in the first 3 days, but to me, that's quite unlikely. Those. So Luda asks, what causes absence seizures in kids, spacing out for a few seconds, especially in the morning when they wake up? Is there a way to naturally treat it? Will they outgrow it? So having an absence seizure is distinctly different, I would argue, than most people with ADHD who are just being inattentive or blanking out. So a seizure is unusually coordinated activity in part of the brain that's disrupting normal ongoing brain function. And I'm not fluent enough in the neurology and of seizures. I mean, I think they probably know what general area is having a seizure in absence, or in the French, absence seizures. I just don't know enough to answer that or to know what. I'm not aware of natural approaches that treat it, and many kids do outgrow it. Um, but usually medications are the treatment of choice as far as I am aware, having had some awareness of kids in the schools my kids went to who dealt with that as an issue. So Max provided a link to alcohol and ADHD. So Dylan talks about being diagnosed with Asperger's, ADHD, OCD, and compulsions. Felt like they were digging him into a bigger hole. Okay. And JC Skate Hills is following up that the reason he was so long on 10 milligrams is it's a transition in treatment people. Jack would like a video on the genetic overlap of ADHD and autism. Maybe that's something I should revisit. Um, yeah, so I will sort of end with Dylan mentions that doctors focusing on things different than what he thinks are the major issue, so including focusing on being gay. I had the fortune of training and living in one of the more enlightened, and at least in that respect, areas of the country in San Francisco. And I'd say, hopefully, you can find a therapist who is a good match for you. And some of it, it's fair to say, I'm aware you're concerned about this being an issue, but to me, that isn't particularly the issue or what I'm having trouble dealing with or struggling with. We can revisit it. Can we focus on the ADHD, or can we focus on the compulsions, or can we focus on the autism and not on the sexual orientation part? So I would say one of the measures of a good therapist is that they can hear your feedback and respond and adjust their own framework to incorporate what's important for you. And the therapy should be therapy for you, not just for them. So thanks for all the great questions and engaging conversation. I saw a question just flash up, but I'll wait till next week. So I'll read it and write it down. Stay healthy, stay happy, and I'll be back same time, same space. So with daylight savings coming up ahead in different times in Europe for the changeover than for the West Coast, and Hawaii doesn't change at all. What I do is I stick with West Coast time. So So the Europeans will be out of sync an hour for a few weeks. And once daylight savings ends in America, I will be shifting an hour from what I'm doing in Hawaii, but it will still be that 10 a.m. West Coast, 1 p.m. East Coast US time. That's when that's sort of my baseline or stability. Um, and yeah, so I'll try to answer the questions that have come up later next time. Bye for now.